the scenarios of heart failure. هل الصوت مسموع ولا لا؟
مسموع تمام يا دكتور محمد.
Okay. So we will start. We will try to cover many cases today. So we complete by this case presentations on heart failure, and next presentation will be on the management of HFrEF essentially. So this is the first case. An 85-year-old woman presented with exertional dyspnea and orthopnea, lower extremity edema. Right ventricular systolic pressure 60 millimeters of mercury.
محمد معلش حضرتك تقريبا عملت ميوت الفترة اللي فاتت.
طيب دلوقتي ابدا اعمل ايه؟ انميوت دلوقتي؟
خلاص كده هتلاقيها طبيعة. حضرتك بس ممكن معلش نبدأ معلش تاني حضرتك بس عشان تبقى الدنيا واضحة.
نبتدي من الاول؟
يا ريت يبقى كتر خيرك.
ابتدي الكيس ولا ابتدي البريزنت؟ 85 year.
بالظبط كده. اتفضل.
85-year-old female presenting with exertional dyspnea, orthopnea, lower extremity edema, blood pressure elevated, heart rate 60, jugular venous pressure markedly elevated 16 centimeter, mild edema of the lower limbs. Echo shows left ventricular ejection fraction 50%, wall thickness 14 millimeters, end diastolic dimension 5 centimeter, left atrial dimensions 4.5, right ventricular systolic pressure 60 millimeter of mercury, mild tricuspid regurg, moderate mitral regurg, and aortic valve area 1.5 centimeters square. ECG shows atrial fibrillation with narrow QRS complex and BNP 300 nanogram. Serum creatinine is mildly elevated and hemoglobin is 10. So what is the most appropriate diagnosis? A, pulmonary arterial hypertension, that's group 1 pulmonary hypertension. B, heart failure with preserved ejection fraction. C, coronary artery disease. D, hypertrophic cardiomyopathy. Obviously, the correct answer is B, is heart failure with preserved ejection fraction. Left atrium is dilated, so you can exclude easily the possibility of pulmonary arterial hypertension. Left ventricular wall thickness is 14 millimeter, unlikely in coronary artery disease, unassociated with hypertension. Hypertrophic cardiomyopathy very rarely and very remotely presents with jugular venous pressure elevation of 16 centimeter of water. So obviously, this gives me the opportunity to discuss HFpEF or heart failure with preserved ejection fraction. Now, as everybody knows that the incidence and prevalence are rising and the admission of this kind of heart failure is increasing. In the very beginning of my training, we thought that this is a very benign condition. Now we know it's as lethal and as serious as heart failure with reduced ejection fraction. If you look to these two curves, which shows the mortality comparison between heart failure with either reduced ejection fraction in yellow, heart failure with preserved ejection fraction in red. Although if you look at the left lower corner of the graph, they look statistically different, significantly different, p-value of 0.02, 0.03. Despite that, if you look to the curves from the back of the room or the front of the room, you will find them that they are almost superimposable. And definitely they are far from being reassuring. So it's a highly lethal condition, almost maybe slightly better than heart failure with reduced ejection fraction, but definitely is a very serious condition. Now, why these patients die? If you look into the left side of the screen, heart failure with preserved ejection fraction in contrast to heart failure with reduced ejection fraction, Heart disease is responsible for more than 50% of mortality in both conditions, although in HFpEF, the non-cardiovascular deaths contribute to almost the other half, and this constitutes only 1/3 of mortality in patients with heart failure with reduced ejection fraction. When we discussed the pathophysiology of heart failure several weeks ago, we alluded to the possibility that the pathogenesis of heart failure with reduced ejection fraction is completely different from heart failure with preserved ejection fraction. In the latter situation, the comorbidities result in liberation of many cytokines, injure the endothelium, produce reactive oxygen species, activate the transforming growth factors, and reducing nitric oxide, which has a protective effect, as well as reducing the phosphorylation of titin. So this pathogenesis of heart failure with the reduced ejection fraction stands alone, completely different from HFrEF, and that's why the treatment is completely different, and that's why the presentation is completely different. And still we look to heart failure with preserved ejection fraction as a compendium of comorbidities, because that is the underlying mechanism by which heart failure occurs in these circumstances. Now, this is obviously an old graph from the European Heart Journal in 2002. If you look to the left side of the screen, female preponderance is evident, but as you see, it's a disease of old age. No longer that's the concept. We now have many reports of heart failure with preserved ejection fraction occurring in the third, fourth, and fifth decades, although female predominance is still holds true at the present time. Now, it's a very heterogeneous disorder, and that's a big problem which should be realized from the very outset. Although in certain conditions like obesity, for example, heart failure occurs with a high cardiac output, although the presentation is heart failure with preserved ejection fraction, it's completely different situation, for example, from the conditions associated with hypertension or diabetes. Atrial fibrillation occurs in almost 80% of these people. So it's a heterogeneous disorders, and it's not a distinct disease entity with very distinct features. It can present with low cardiac output, with high cardiac output, with normal cardiac output, and a variety of conditions. So it's a large bag of collecting so many cardiovascular disorders. Now, as everybody knows, that the diastolic dysfunction is an important contribution to this situation, although whether that should be present in 100% of these kind of patients is still debatable. But it's a reality that we have other important contributing factors, impaired systolic function, particularly on exercise, which we call as impaired systolic reserve, subtle abnormalities in contractile dysfunction as evidenced by strain measurements, chronotropic incompetence. You examine the patient while he is resting, find the heart rate at 70, 72. But ask the patient to walk around the room or on the corridor. He just builds a heart rate up to 80, 85. So under these circumstances, you don't need to give beta blockers. You have to stop beta blockers in order to avoid the chronotropic incompetence. It's a stiff heart situation, but again, the vessels are always stiff. And the stiff heart with the stiff vessels, this is called impaired ventriculovascular coupling. So as a result of that, you get elevation of the blood pressure from vascular stiffness. Any mild alterations in the cardiac output can produce fluctuations of the blood pressure, high blood pressure, low blood pressure, and this is an important contribution to the liability of the clinical presentation of this kind of patients. It's important to realize that this is a condition of diagnosed by exclusion of other stimulating conditions, including coronary artery disease, valvular disease, arrhythmias, hypertension, pulmonary hypertension, anemia, obesity, and particularly pericardial disease. So under these circumstances, all these conditions should be looked for, excluded before the diagnosis of HFpEF. Now, experts in the field claim at least that systemic amyloidosis contributes almost 5 to 10% So if we are talking about half patients with heart failure heart failure with preserved ejection fraction, 5 to 10% out of this contributes to a huge number of patients with amyloidosis. As a matter of fact, many of the features which have stood the test of time in amyloidosis are changing now. So the speckling pattern is no longer considered as a sensitive feature of amyloidosis. It should always be considered in the differential diagnosis of HFpEF. Sometimes it doesn't exist alone; it exists with other conditions. For example, patients who underwent cabbage, or patients who underwent TAVR or aortic stenosis surgery. Many of the patients with atrial fibrillation, because as I told you, atrial fibrillation is a very important component of HFpEF, contributing to about 80 to 85% of patients with HFpEF.
دكتور محمد حضرتك سامعني؟ الصوت مختفي عن الجميع مش كده؟ وكده شكل النت فصل مع الدكتور محمد، هو هيدخل دلوقتي. هو دكتور محمد يا جماعه، بس النت فيه مشكله، هتحل على طول دلوقتي حالا، هيدخل تاني.
كده يا ياسر؟
كده تمام يا دكتور محمد، اتفضل يا فندم.
So in amyloidosis, one of the clues to the diagnosis is whenever you have a heart failure with markedly elevated BNP. In heart failure with preserved ejection fraction, BNP is elevated, but not much because the distension of the ventricle is restricted by the extensive fibrosis in the myocardial in the myocardium. But if it is elevated in thousands, then you have to think of cardiac amyloidosis. Now, previously, it was a diagnosis based on biopsy, and still the situation holds true as of now. But if you think of heart failure with preserved ejection fraction and you think of amyloidosis, then an analysis of light chain in serum or in urine for detection of AL amyloidosis and bone pyrophosphate. Bone pyrophosphate usually detects the transthyretin amyloidosis. If both are negative, if AL analysis in urine and serum and bone pyrophosphate is negative, both of them, then it's very unlikely that the case is amyloidosis. So many people now are starting to diagnose the condition non-invasively based on clinical suspicion and bone scintigraphy, in addition to analysis of urine and serum for light chain amyloidosis. Now, because it is important not to miss pulmonary arterial hypertension in these conditions, because we have at least 14 targeted lines of treatment for pulmonary arterial hypertension that are almost all of them contraindicated in patients with HFpEF. So under these circumstances, it's important to differentiate between pulmonary arterial hypertension and heart failure with preserved ejection fraction. If we look to these 6 factors: age above 60 years, comorbidities, valvular heart disease, left ventricular dysfunction, echo abnormalities, and BNP that's markedly elevated. If all of these are absent, then the diagnosis is for sure, is pulmonary arterial hypertension. If 3 or more are present, then pulmonary hypertension is usually type 2 secondary to left-sided heart failure, and under these circumstances, it's the HFpEF. If it's just 1 or 2 of these 6 factors are present, then it is probable that the pulmonary arterial hypertension is secondary to left-sided heart disease. So that's important because pulmonary arterial hypertension, the commonest cause is type 2, which is secondary to left-sided heart failure. And it's very common to be confused with pulmonary arterial hypertension, and the treatment, as you know, is completely different. Treatment. If you look to the important studies, the SHARM-PEF, the iPreserve, and other studies for patients with HFpEF that have been studying ACE inhibitors, ARBs, as well as beta blockers, you look at the bottom panel, and you will find that the p-value is always non-significant. So none of this is actually working in patients with HFpEF. That comes to no surprise because, as I alluded to, the pathogenesis of HFrEF is completely different from that of HFpEF. This doesn't apply to the TopCat trial, which was studying the effect of mineralocorticoid antagonists on patients with HFpEF. The study primary endpoint was negative study. The primary endpoint was all-cause mortality, and as you see here, there was no difference between spironolactone therapy and placebo in these patients. But if you look to hospitalizations, keeping the patient out of hospital with symptomatic improvement, there is a significant improvement with the spironolactone. But the problem of this study is that a part of the study was carried in East Europe, and the post-hoc analysis of the study revealed that many of the patients enrolled in the study didn't have HFpEF. They had pneumonia, they had pulmonary infarctions, and other things. So the study is going to be repeated. But for the present time, a spironolactone can be used for symptomatic relief in these patients. Now, going to the guidelines, Class 1 indication is to treat hypertension and to give the patient diuretics to get rid of dyspnea. Anything else is class 2 recommendation, including revascularization, treatment of heart failure, atrial fibrillation, using beta blockers, ACE and ARBs for hypertension, using ARBs to decrease hospitalization, and the same applies according to the TopCat existing result now. Aldosterone antagonists also are used to decrease hospitalization. Now, class 3, harm. Don't give these patients nitrates, at least in the HEAT HF trial, they increased mortality, and don't give the patient sildenafil because in the relaxed HF trial, it was associated with a hazardous outcome. Now, second case, 45-year-old man with a 5-year history of heart failure, left ventricular ejection fraction 30%. The patient was suffering from a familial non-ischemic cardiomyopathy, was admitted for the second time in a year with decompensated congestive heart failure. Blood pressure is normal, heart rate 100, respiratory rate 24, jugular venous pressure again elevated 16 centimeter, normal first and second heart sound, probably possible soft third heart sound. There is 2+ leg edema, sodium is normal, BUN 24, serum creatinine is normal, cardiac enzymes are negative, and the ECG is unchanged from baseline. Now, based on these findings, how can you classify these patients' hemodynamic? This is the Lean-Stevenson 2-minute hemodynamic assessment known to most of you, but I will explain it. Is this patient warm and dry, or warm and wet, or cold and wet, or cold and dry? This is a very simple classification, applies to chronic as well as acute heart failure, called the 2-minute hemodynamic assessment, and is based on the following. It's the 2x2 table, and it classifies patients into with heart failure, acute or chronic, into warm and dry, which is almost normal, or second stage B heart failure, warm and wet, cold and wet, or cold and dry. And this classification, although as simple as it looks, is very helpful in defining at least the initial lines of therapy in these patients. How can you classify these patients? If you look to the right-sided column, patients are wet if they have the following manifestations. If he's orthopnea, if he's having the new sign, which is bendopnea, and this is getting dyspnea on bending forward, like tightening the shoes, for example. If the patient is having an elevated jugular venous pressure, or he has a positive response to Valsalva, if he's having edema, or he's having crepitations on the chest. So all of these conditions indicates that the patient is wet. Whether the patient is cold or warm, this is indicated by presence of cold sensation, pressure, particularly if the proportional pulse pressure, which is the pulse pressure divided by the systolic blood pressure, is less than 25%, which connotes a cardiac index less than 2.5 liter per square meter body surface area per minute. So this is a very easy classification, very important to help the initial identification of the line of treatment. So if you look here, you will find that if the patient is warm and wet, which is the commonest presentation in patients with heart failure, these patients are indicated for diuretic therapy. If they are cold and wet, which is the second common presentation in patients with heart failure, you give them diuretics, inotropes, and vasodilators. So it's wrong to institute inotropic therapy or vasodilator therapy in patients who are warm and wet. So our patient here is warm and wet. So based on that, the patient started to take furosemide 40 milligram BID, Zestrel 5 milligram BID, carvedilol 25 milligrams BID at home. Which of the following could you choose for your initial therapy in the hospital? Oral furosemide 80 milligrams per BID, intravenous furosemide 60 milligrams BID, milrinone 0.25 microgram per kilogram per minute, dobutamine, or intravenous nitroglycerin. Obviously, the last, this is a warm and wet patient, so Positive inotropic agents or vasodilators shouldn't be instituted according to the guidelines. And the guidelines indicates that if the patient is congested, gets admitted to the hospital because of acute decompensated heart failure, you should change the oral medications into intravenous medication. And usually we start by the equivalent dose to the oral medication, but given intravenously. Whether you give it a bolus or you give it intravenous infusion, according to the dose trial, they are equivalent. So the guidelines are this. Patients with heart failure hospitalized with fluid overload should be treated with intravenous diuretics. And they should receive an initial parenteral dose equal or greater than the chronic oral therapy that the patient has been taking, and then you serially adjust it starting from that point. So overnight, the patient did not diurese well. Serum creatinine remained stable. Which of the following would you recommend? Add low-dose dopamine, start ultrafiltration, add milrinone in this dose, stop intravenous furosemide and start torsemide, or increase intravenous furosemide 120 milligrams BID. Now I want to make a comment on each of this. First of all, low-dose dobutamine in all the trials proved of no value, and I will show you the results which supports the studies that support that. Starting ultrafiltration failure, you shouldn't start ultrafiltration except when you exhaust the class 1 indication, which I'm going to come to. Add milrinone is not going to help in any way. This patient is warm and wet, so no point in giving him inotropic support. Stop furosemide and give him torsemide. You are giving furosemide here intravenously, so bioavailability is 100%, so there is no advantage of torsemide. Although torsemide, in addition of being a long-acting loop diuretic, it has also an antifibrotic effect, at least in experimental animal, so it carries a slight advantage. But the guidelines recommended that if the patient doesn't respond to intravenous furosemide, you increase the dose. And actually, we increase the dose of furosemide by doubling it. So if you are starting with 60, you change it to 120. Don't change it to 80 or 100, 120. And if you want to decrease, you half the dose. Don't decrease it slightly, you have. So this is the guidelines. When diuresis is inadequate, it is reasonable to either give a high dose of intravenous loop diuretics by doubling the dose, or you add a second diuretics like thiazide, particularly metolazone, which is Methenix or Zaroxylene. Now, this is the CARES study, which is a large randomized study studying the effect of ultrafiltration on 60-day event rate. And as you see here, for whether you are looking for mortality or heart failure hospitalization, there is no difference. And on the other hand, serious adverse effects were more marked in patients with ultrafiltration. But because ultrafiltration was successful in many observational as well as smaller randomized trials, so the guidelines didn't eliminate it. Actually, is putting the ultrafiltration as class 2B with level of evidence B or C. So ultrafiltration should be considered in patients with obvious volume overload. Obviously, that should be done in consultation with the nephrologist. Most of the patients, they usually respond to a higher dose of furosemide, whether you are giving it by intravenous infusion or boluses. Now, this is a study about the low-dose dopamine and low-dose neseritide in patients with acute decompensated heart failure. These graphs are showing the effect of low-dose dobutamine, and as you see here, there is no difference as far as volume of urine, and no difference as far as the renal function as estimated by cystatin C. So on increased dose of dopamine, of furosemide, the patient now diuresed well. Which of the following is true regarding the use of beta blockers in this setting? Carvedilol should be discontinued throughout hospitalization because the patient is volume overloaded, or carvedilol should be converted to metoprolol succinate, or the patient should be on beta blocker at the time of discharge if you volemic and hemodynamically stable. And lastly, should the patient be placed back on beta blockers when he is seen in follow-up after discharge and found to be stable? Now, if you look here, carvedilol should be discontinued throughout the hospitalization. We don't usually discontinue carvedilol unless the patient is in one of two situations: pulmonary edema, or he is on inotropic support. And as you see, our patient here is not in pulmonary edema. He's congested, but not in pulmonary edema, and he started to respond to diuretics. Metoprolol is a selective beta antagonist. It's better than patients who are taking carvedilol, which is a non-specific beta antagonist, as well as alpha antagonist. It's usually used in young individuals, particularly asthmatics, and this doesn't apply to our patient here. Let's go to C. There is strong evidence that you start beta blockers at the time of discharge and not after discharge, and I will show you this study which supports that. So the guidelines indicates that patients requiring heart failure hospitalization on guideline-directed medical therapy should continue on that kind of therapy unless hemodynamic instability or contraindication is existing. And you should initiate beta blockers at a low dose and optimize after optimization of the volume status of the patient and discontinuation of intravenous agents. So the correct answer here is C. The patient should start beta blocker before leaving the hospital. And here is the IMPACT HF study, which compared the patients who are advised to take carvedilol pre-discharge against those who are starting beta blockers post-discharge. And you'll find that the survival at 60 days was statistically significant difference between patients who are taking carvedilol before leaving the hospital, because in the hospital you are sure of the volume status of the patient and he is free of the indication for inotropic support and is not having volume overload as revealed by pulmonary edema. After discharge, that might not be as easy as during the hospitalization. So what the guideline says when the patient leaves the hospital? Before hospital discharge and at the first post-discharge visit and in subsequent visits, you should optimize chronic oral therapy, assess the volume status of the patient, make sure that the blood pressure is adequately controlled. At the same time, patient education and insurance of adherence to therapy is important. A follow-up visit after 1 or 2 weeks is important, and within the first 3 days, post-discharge, connection with the patient by telephone call or something similar to that is important. So I go to the next case. Now the next case is actually an exercise in the fundamentals of late gadolinium enhancement. I will show you a variety of conditions characterized by different types of late gadolinium enhancement, and then I will show you vignettes and ask you which vignette is compatible with the late gadolinium enhancement. So if you look to A here, look to this picture to the right here. This is a picture, short axis of the left ventricle, and there is a late gadolinium enhancement in this situation. Now you look to the second, there are some arrows here, late gadolinium enhancement located in this location. If you look to C, there is a short axis view and a 2-chamber view here, and there is a circumferential late gadolinium enhancement with some arrows located here. And then there is a 4-chamber view here and a systolic view. And as you see, the systolic view here is producing a special pattern, and there is no late gadolinium enhancement of this patient. And if you look into the last one here, you will find late gadolinium enhancement located in this area. So I will go back to the cases, and then First case, a 31-year-old woman with severe chest pain that exceeds any other type of pain experienced previously. She has a serum troponin of 6.5 and the serum troponin 6 hours later of 6.2. So what do you think this patient clinically is having? The answer is this patient is having most likely myocarditis. So there is no change there. Which one of these is going to support the diagnosis of myocarditis? It's actually E. E here, you will find the delayed gadolinium enhancement is epicardial based. So myocarditis, epicardial based delayed gadolinium enhancement. And usually it's in presence in a non-coronary distribution. So the clinical situation is very persuasive of myocarditis, and the support of the MRI comes from the epicardial location of the delayed gadolinium enhancement. Now the second case is a 40. Now the second case is 46-year-old man with 3-hour history of substernal chest tightness, jaw pain, left arm pain, dyspnea, nausea, serum troponin at presentation 1.6, 1.7, and 6 hours later 48. So what do you think this patient is having? Myocardial infarction. So this is a patient with myocardial infarction. Which type of late gadolinium enhancement here is compatible with the diagnosis of myocardial infarction? B. B is a subendocardial or an endocardial-based late gadolinium enhancement, and this is indicative of the presence of necrosis and the extension of widening of the extracellular spaces in patients with myocardial infarction. So under these circumstances, you will find that the clinical diagnosis is persuasive of a recent myocardial infarction, and the MRI supports the diagnosis. Now, case 3, a 69-year-old woman with 9 months of intermittent chest pain, progressive dyspnea on exertion, lower extremity edema, serum creatinine is elevated, estimated glomerular filtration rate is 44, serum troponin at initial presentation is 0.002, and serum troponin 4 hours later is undetectable. What do you think this patient is having? An elderly female, 9 months chest pain, progressive dyspnea, lower, and is having renal failure. So what do you think this patient is having? Now this patient is very suggestive of amyloidosis. So this is a renal failure, heart failure, elderly female, no change in serum troponin, and almost undetected. Which one of these goes with the diagnosis of amyloidosis? C. C is an AL amyloidosis, and as you see here, a subendocardial circumferential location of the late gadolinium enhancement. This is almost a pathognomonic of AL amyloidosis. There are special patterns for the TTR amyloidosis, but this is an AL amyloidosis involving the kidney as well as the heart. So under these circumstances, the MRI is very, very helpful under these circumstances. Remember, strain measurements reveals the apical sparing, as we alluded in the previous time. Now let's go to case 4, 41-year-old man with 4-year history of dyspnea on exertion, periodic pleuritic chest pain, he began to have a flu-like symptoms in 2011, and initial troponin was 0.005, serum troponin 4 hours later 0.007. So he's a 40-year-old man and is having pleuritic chest pain long ago, and so what this clinical scenario points to? It points to a cardiomyopathy. So if you look here to the delayed gadolinium enhancement, which one is supportive of the diagnosis of cardiomyopathy? It's A. You get a mid-wall late gadolinium enhancement. Mid-wall late gadolinium enhancement is actually a very nice specific situation. It can be present in patients with myocardial infarction starting subendocardially as in B and moving towards the mid-myocardium. At the same time, it can exist in patients with cardiomyopathy, as in this case, or long-standing hypertension, patients with diabetes and developing diabetic cardiomyopathy. Now, if you look into the last, sorry for what's happening, but I don't understand why this is blinking all the time. Case 5. A 55-year-old woman with abrupt, within 3 hours, onset of dyspnea and sharp chest pain after recent death of a sibling. Initial serum troponin 0.7 and serum troponin 6 hours later 3.6. Now, what do you think this is? This is Takotsubo, an elderly female, and minimal change in serum troponin, and there is a very disturbing emotional upset. So which one of these is compatible with the diagnosis of Takotsubo? It's D. And as we alluded to in the previous time, patients with Takotsubo, usually they don't have a late gadolinium enhancement. If they have a late gadolinium enhancement, it's usually restricted to the ballooned area, and it connotes a poor prognosis in these patients. So this is for the general cardiologist, some MRI hints, which is based on the diagnosis of late gadolinium enhancement. And if you know these, this is the important points about late gadolinium enhancement. It helps the good communication between the radiologist or the MRI specialist and the general cardiologist. Now let's move to the next case. This is a 58-year-old man with progressive dyspnea on exertion and fatigue, past medical history of hypertension, poorly controlled, stage 3 obesity. On physical examination, he is slightly hypertensive, markedly obese, and this is his ECG. This is his ECG. It's the atrial fibrillation, pretty well controlled, left ventricular hypertrophy and strain, and the echo shows left atrial restricted features in the left corner, pulmonary hypertension, and in the upper right corner there is plethora of the inferior vena cava. So the patient underwent cardiac catheterization, revealed the presence. سامعني يا ياسر؟
سامعك يا محمد.
سامعني؟
ايه يا فندم سامع حضرتك، بس كان في صوت كده مشوش شويه.
بيغوش كده اللي في عذاب الانترنت. So the cardiac catheterization revealed the minimal diffuse coronary artery disease, right atrial pressure slightly elevated, pulmonary artery mean pressure 48. Remember, the definition of pulmonary hypertension changed from 25 mean pressure at rest to 20 mean pressure at rest. So 45 is a severe hypertension. Pulmonary artery wedge pressure is 18. So if you subtract 18 to 45, you get the pulmonary, which is 20. If you divide 27 by the cardiac output, you will get pulmonary units. Patient is having pulmonary vascular resistant 4 units, pulmonary gradient 27, cardiac output 6.8, and cardiac index 3.2. Pulmonary wedge pressure is slightly elevated, and pulmonary artery pressure is markedly elevated. So the question is, what's the next most appropriate diagnostic step? Is it Holter monitor? Is it cardiopulmonary exercise test? Is it a sleep study, perfusion ventilation scan, or ambulatory oxygen study? So if you look at this patient, it doesn't have arrhythmia, so no point in putting him for a Holter monitor. Cardiopulmonary exercise test will not add anything. We know that the patient is in advanced heart failure, biventricular failure, wall thickness, restrictive cardiomyopathy, and the VQ scan is not going to help. Patient has an affection of the left side of the heart, so it's unlikely to pulmonary embolism. So it's a sleep study. So this gives me the opportunity to talk for some time about obstructive sleep apnea. This patient is having fatigue, is obese, is having fatigue, is having shortness of breath, is having biventricular enlargement, and the marked pulmonary hypertension. So the diagnosis essentially rests on the polysomnograph. The polysomnograph usually includes an EEG, an electrical occulogram, hemodynamic study, an electrocardiogram, oxygen saturation, respiratory effort, and airflow. If you have a lot of respiratory effort and no airflow, that's obstructive sleep apnea. If neither is present, there is no effort and there is no airflow, so this is essential sleep apnea. So as you see here, the risk factors in patients with sleep apnea essentially involves obesity. And this man is having, our patient here is having advanced obesity, stage 3 obesity, with BMI quite high. But in addition to that, male sex, oropharyngeal, excessive oropharyngeal tissues, presence of a stroke, retrognathia or small mandible which is retracted, alcohol, old age, and cardiomyopathy. So all of these are risk factors in patients with sleep apnea. Obstructive sleep apnea is characterized by breathing cessation frequently more than 5 times per night, each time more than 10 seconds. Is associated with cyclical saturation and desaturation of blood and cyclical change in sympathetic flow. And as a result of the cyclic changes in desaturation and saturation, as well as the cyclic changes in sympathetic flow, these patients get a variety of metabolic and cardiovascular events: stroke, systemic as well as pulmonary hypertension, congestive heart failure, glucose intolerance, and diabetes. And probably the metabolic disturbances are secondary to the sympathetic cyclical changes. In patients with heart failure, the occurrence of, in most studies, the occurrence of central sleep apnea is commoner than in obstructive sleep apnea. But obviously, if the patient is obese as well, then you get a combination of central sleep apnea as well as obstructive sleep apnea. A few years ago, we had something called adaptive servoventilation. This is a ventilator that adjusts all the parameters automatically. But it turned out that it increases the mortality in patients with central sleep apnea, so it disappeared from the scene. Patients with obstructive sleep apnea, they are associated with increased mortality in patients with cardiovascular disease, so more fatal cardiovascular diseases, and also more non-fatal cardiovascular diseases. Now, in many observational studies and the small randomized studies, CPAP was working well. But in the only randomized studies which involved almost 2,600 patients, there was no effect of CPAP on cumulative MACE. So as you see here, the two curves are superimposable and the p-value is 0.34. So now the main advantage of CPAP is to improve blood pressure, endothelial dysfunction, and insulin sensitivity. But in randomized controlled trials, no change in mortality, cardiovascular complications. But the reason of that is a poor adherence of patients to CPAP. Usually the patients require sleep somewhere between 6 and 8 hours, but in most of the studies, they were adherent to the utilization of CPAP for almost 3 hours. So most of the night they spend the night sleeping without CPAP support. As everyone knows, that to be adherent to this line of therapy is extremely difficult. So actually, in obstructive sleep apnea, the pathogenesis of pulmonary hypertension is very similar to the pathogenesis of pulmonary arterial hypertension. As a result of the upper airway obstruction, you get hypoxia, you get sympathetic stimulation, you get pulmonary vasoconstriction, and as a result of this pulmonary vasoconstriction, pulmonary vascular remodeling, and the elevation of the pulmonary arterial pressure. Usually, the elevation of the pulmonary arterial pressure in these patients is mild, unless it's associated with comorbid conditions which are frequently present. This includes obesity, left ventricular dysfunction, COPD, and other interstitial lung disease. So if you have an association, then usually the pulmonary artery pressure is elevated in this patient. So the degree of pulmonary hypertension is in obstructive sleep apnea is generally, if it is existing alone, the obstructive sleep apnea, generally the degree of pulmonary hypertension is mild. But if the patient is having comorbidities like obesity or HFpEF or COPD, then it contributes to marked elevation of the pulmonary arterial pressure. It's important to assess the patients for obstructive sleep apnea and treat obstructive sleep apnea before instituting the specific pulmonary vasodilators. So targeted therapy is not going to work unless you control the obstructive sleep apnea. So this is the permissive effect of obstructive sleep apnea treatment on the treatment of PH therapy. Now, next case. 71-year-old male patient with history of ischemic cardiomyopathy, ejection fraction 10, admitted for the third time in the past 4 months with heart failure. At baseline, when he is almost free of symptoms, he is complaining of dyspnea and doing very minimal effort. A past medical history is having type 2 diabetes, renal insufficiency with creatinine 1.7. He had cabbage times 5 3 years ago. This is his medication. And the physical findings: blood pressure 96/68, heart rate 84, lungs are clear, heart is enlarged, second chart P2 is elevated, is loud, jugular venous pressure is borderline, right ventricular heave, and the liver is enlarged. BUN and serum creatinine are elevated. Serum creatinine is 2.1. Now the question is, as you diurese, the patient says, he says that he wants everything to be done. So the appropriate therapy includes up-titrate his beta blocker, refer him to transplantation, refer him to LVAD, or stop Lezestrel and wait for 2 days and start him on Entresto in this dose. So let's go through them one by one. Up-titrate the beta blocker. This patient is having a marked congestion, and so it's not the appropriate time. He's also hypotensive, blood pressure is 96, so it's not the ideal time they will not tolerate beta blockers. Refer to transplantation. Patient is 71. Most of the centers in the West, they don't accept patients except after the age of 70. So in addition, serum creatinine is 2.1. And immunosuppressive therapy usually elevates serum creatinine, and most centers don't accept this figure because renal deterioration is going to hamper the results of the transplantation. Stop lisinopril and start Entresto. The patient is hypotensive and he's not fit for increasing. We know that Entresto lowers the blood pressure even more than lisinopril. So this brings us to discuss stage D heart failure. If you look into the middle of this panel, you will find that we have a lot of therapeutic measures for the treatment of stage C heart failure, including diuretics, ACE inhibitors, ARBs, mineralocorticoid antagonists, digoxin, etc., etc. But if you look to the right side of the slide, you will find that the options for stage D heart failure are very limited. Palliative care, don't forget palliative care, always consider it in stage C, D heart failure. Transplantation if the patient is fit for that, and LVAD is a class 2A recommendation. And then investigations, drugs which might come and go and may succeed and may not succeed. So actually, for stage D, we have only 3 alternatives: palliative care, transplantation, or LVAD. Now, the guidelines indicate that LVAD is indicated as a bridge to transplantation if the patient is a candidate for transplantation, or as a destination therapy if the patient is not a candidate for transplantation. So these are the 2 important indications. The other indications is a bridge to decision when the patient is having a problem that can go away, like sepsis, for example. You correct the sepsis, the patient becomes fit for transplantation, you put him temporarily on LVAD, waiting for transplantation. Or as a bridge to recovery, if the patient is having a momentary condition or a recent myocarditis, or as a bridge to bridge. in which a patient is put on a temporary LVAD, temporary assisted device, waiting to transfer him to a more durable assisted device. So among these 5 bridges, the only 2 that are commonly used is bridge transplantation and bridge to destination therapy. So the patient received an LVAD. Initially, he did well. 8 months later, he was seen in the clinic complaining of exertional, progressive exertional dyspnea. On examination, jugular venous pressure is almost normal. He is having a pump hump, which is a common thing in these patients. And the most common reason for his dyspnea is it worsening of heart failure, gastrointestinal bleeding, pump malfunction, or LVAD-induced pneumothorax. Now, this patient is having a normal jugular venous pressure, so it's unlikely to be having worsening heart failure. Gastrointestinal bleeding is very common, but that this patient is not bleeding. There is no evidence from the stem that he is losing blood. Pump malfunction, this is becoming rarer with the introduction of the continuous flow devices. LVAD-induced pneumothorax, because usually the pump erodes through the ribs and it produces pneumothorax. So the correct answer here is pneumothorax. So now, based on the rematch trial as well as other smaller trials, we know and we are very cognizant now. We are very cognizant now of the advantage of LVAD in increasing survival of this type of stage D heart failure. But usually the results are not that impressive, and there is an LVAD misery in contradistinction to the advantage of improving survival. So this includes bleeding. Bleeding occurs within the first 3 months in about 1/3 of the patients, and after the first 3 months in 1/4 of patients. The bleeding is usually the result of adding anticoagulants to the pump. The pump is a continuous flow, rotating at a rate of 3,000 to 8,000 per minute. They shred and cut the meltemeres of the bone brand factor, so they get a coagulopathy. So in addition to the anticoagulation and the exposure to foreign surface and the presence of bone brand, these patients always are having continuous flow, no longer pulsatile flow as previously was the situation. And this continuous flow creates arteriovenous anastomosis in the gastrointestinal tract. So all of this is responsible for the huge number of bleeding events which occur in these patients. Arrhythmia can occur in about 1/4 of patients. Device malfunction is less common with the continuous flow in contrast to the intermittent flow or pulsatile flow. Infection always there, it can never be controlled, usually around the electrical line that's connecting the battery with the device. Many of these patients, they get a stroke, both hemorrhagic and embolic, and many of them get readmitted because of renal dysfunction and other events. So as you see here, LVAD is not something which is to be taken easily. It's associated with misery and is associated with many complications, and almost all patients get admitted several times, so should not be instituted unless it's strongly indicated and there is no other way to treat the patient with. Then we have the last case, 19-year-old male with orthostatic heart transplantation for idiopathic dilated cardiomyopathy. He was discharged after 9 days from the hospital, get readmitted after 2 weeks for treatment of rejection. He did well for a year, had coronary arteriogram, which revealed the normal coronary arteries, but he had a high elevated wedge pressure. Within the subsequent week, he complained of gastrointestinal symptoms. Liver enzymes were elevated and became more elevated as time went by, and he was asked to do a CMV serology and come to the clinic. So this is his electrogram. If you look to the electrogram, there are arrows here which point to a large number of P wave completely dissociated from the QRS complex, although the heart rate, the ventricular rate is slightly wider, but this is a complete heart block or at least sinus tachycardia with AV dissociation. So this patient is having right-sided heart failure evidenced by the high liver enzymes. Now he is in the second year, and at the same time he is suffering from heart failure and heart block as well. So the question is, what's the most appropriate next step? Core electrophysiology for permanent pacemaker implantation, stop his beta blockers, do endomyocardial biopsy, or cath the patient again. Now let's go one by one. Previously, the heart transplantation was done by the biatrial anastomosis. The recipient atrium is connected to the donor atrium. Now, no longer since the late 1990s, it's now bicaval anastomosis. So previously, we used to have two sets of P waves, the donor P wave and the recipient P wave. No longer that, but the bicaval anastomosis, you get one single P wave, and here you have one single P wave. Sinus tachycardia because of denervation hypersensitivity. And this patient is having heart failure as well in addition to the heart block or AV dissociation, which might point to the presence of rejection. So stop the beta blocker. Obviously, if the patient is having AV dissociation, beta blocker should be stopped. But the important thing is that he should have an endomyocardial biopsy. Cardiac catheterization is not going to add anything. He added just at the end of the first year. Now, this is a busy slide, but it shows again what are the complications, the famous complications of heart transplantation, whether in the first 30 days or after the first 30 days in 1 year, 1 to 3 years, and so forth until the 15th year. Now, early on, the main complications are infection, both viral and bacterial, as well as rejection. So these are responsible for the complications within the first few months. And both rejection and infection with septicemia can result in multiple organ failure. This is the kind of patients who might not come out of the hospital right at the beginning, or they die within the first few months. Later on, the two problems are vasculopathy as a result of the reaction of the recipient coronary arteries to the hostile environment of the recipient, as well as malignancy. So malignancy here involves essentially the skin, particularly squamous cell carcinoma, and lymphoproliferative disease, which involve essentially the gastrointestinal tract, hilum of the lung, as well as the thoracic chain of lymph nodes. This might force you to come down with the anti-rejection regimens, which include the calcineurin inhibitors, antimetabolites, as well as steroids. At the same time, you might institute chemotherapy as well as the radiotherapy. So even heart transplantation is associated with misery, and this misery manifests itself early on as a rejection, or as an infection, or as multiple organ failure, and later on, after the first year, by vasculopathy as well as malignancy. So I'll stop at this stage and get questions. I'm sorry for what happened tonight because of the disturbance created by the very shaky internet. سمعني يا ياسر؟
سامع حضرتك كويس جدا.
اوكي.
دكتور محمد، عايز اسال حضرتك عن الفاميليال كارديوميوباثي. بعض الاحيان بنعالج فاميليز عندهم more than one family member with typical dilated cardiomyopathy.
خلاص كده. اثنين من الفاميلي بقى فاميليا.
اوكي. هل في سبيشال مانجمنت بالنسبه للفاميليال كارديوميوباثي؟ هل نقدر نعمل لهم جينيتيك كونسلنج؟ هل الاوف سبرينج بقيه العيله نقدر نديها حاجه بروفيلاكسس ولا جاست فولو اب؟
نمسكهم واحده واحده. اولا انك انت تشخصها فاميليال دي كلينيكال دايجنوستس، فده مش عاوز جينيتيك تيستنج. الكلاس 1 ريكومنديشن and these patients should be followed by an echocardiogram, and the role of genetic testing is not as a routine is not indicated. Like in 2A is a routine, so there is a panel usually involving the commonest 50 or 50 something mutation. You look for the most affected person in the family and consider him the proband, and then you test him by the 50 gene panel, and if you detect a mutation concentrating essentially on emerine as well as titine, because these are the two common things, and if you find it, then you check the first degree relatives for that particular gene abnormality. Now, if he is positive for the gene abnormality, then you check him periodically by echo. If he is negative, then you stop at this stage. If you can't identify the genetic abnormality completely because he is having a genetic abnormality not included in the panel, which includes 50 gene abnormalities or mutations. So under these circumstances, you follow them by echo. Now, why you are following them by echo? That's الجزء الثاني من السؤال بتاع حضرتك. And these patients, they started to move between stage 1, stage A, which is having a predisposition, and here the predisposition is a mutation. So these patients, if you institute for them an early beta blockers and ACE inhibitor or mineralocorticoid antagonists or ARBs, then under these circumstances, for sure, you delay the occurrence of hypertrophic cardiomyopathy, of dilated cardiomyopathy. If they move to stage B, which is a structural heart disease, and you catch the patient under these circumstances, then usually you retard the progression from stage B to stage C. How can you identify these patients? You identify them by repeated echo examination. How close the guideline says every 3 to 5 years, and you might need to do it more closely if you find. Usually we start with one echo at a certain point of time, and then do the second after 6 months to make sure that there is nothing progressing rapidly. If it's progressing slowly, then every 3 to 5 years. So the two parts is that the genetic studies, yes, at least 2B is a routine genetic study, and the algorithm, as I alluded to, is very clear, and the follow-up by echo is important because you wanted to prevent by the existing armamentarium of therapeutic measures the progress from stage A to stage B to stage C to stage D after. Did I answer your question?
تمام. امتى لو حسيت ان عيان الدايليتد كارديوميوباثي اتحسن، الكلينيكال سندروم اتحسن، الايجكشن فراكشن اتحسن، بالظبط، امتى انا justified ان انا
one added thing is that these patients should be on alert that they don't take cardiodepressant drugs, for example the immunosuppressive drugs or the chemotherapeutic drugs, because they are very vulnerable patients.
Okay. امتى وقف علاج الهارت فيلير؟
If you have definite evidence that it's a transient condition. Remember last time when we talked about the Herceptin or trastuzumab, this is usually a very temporary event. So you give it for a year and then for 1 year, and then you stop it. Most of the time, either the heart is not even affected or the heart recovers completely. If he recovers completely and the patient followed up for 6 months or so, then you might try to stop the treatment and watch the patient. If you watch the patient and then he starts to develop heart failure, institute the treatment again and continue for life. Otherwise, you can stop. If the patient is having a myocarditis that looks like a benign condition and he is recovering from it, usually the presentation is heart failure or chest pain, and you can control the myocarditis, everything cleared up, then it might be reasonable to stop the medication and watch the patient. But in the large majority of patients, if they have recovered the heart failure, which is an entity by itself, although not very clear in the guidelines because there is no actual studies, you continue the treatment.
So it's long life treatment طالما ان في evidence of heart muscle disease.
It's a lifelong treatment exactly, so long as we have something that started to remember. A part of the pathophysiology is that you get a regression to the fetal type of myosin. So that is irreversible changes. Fibrotic changes which occur in heart failure is irreversible. So many of the changes are irreversible. We are treating the periphery of heart failure. We are treating the maladaptive mechanisms, the neurohormonal abnormalities, salt and water retention. We are not doing anything for the engine, for the heart itself. So you have to be very alert to that. If you try to do something for the engine, you kill the patient. You give the patient inotropic support. All inotropic supports kill the patient. If you give dopamine, dobutamine, milrinone, all of these things increase mortality. Even digoxin increases arrhythmic mortality, and in females increases arrhythmic and non-arrhythmic mortality. So inotropic support is not the answer. The new drugs like myosin sensitizers, omecaptive mecarbil, which sensitizes the myosin to calcium, may turn out to be helpful. There are many studies now testing this compound because they increase doesn't increase the rate of rise of ventricular pressure, but it increases the duration of rise of ventricular pressure. So it works as an inotropic agent by a different mechanism. Whether that's going to deviate from the bad effect of inotropic therapy in increasing mortality, we don't know. But people are working on inotropic support that does not increase mortality.
دكتور ياسر اتفضل بقى نشوف الأسئلة بتاعت الناس.
اتفضل.
في سؤال.
علي صوتك شوية.
في سؤال حضرتك.
أيوه.
Use of metformin to decrease weight in non-diabetic patients.
No. Answer clearly no. All guidelines no. You shouldn't use metformin to. It will let you use weight, but the studies didn't support that. Don't use metformin as an anorectic drug or drug which Victoza الليرالوبيتايد بس الدوز بتاع الفيكتوزا اللي هي الليرالوبيتايد is 3 times as large as the anti-diabetic dose. So this is a point to be taken in consideration at the same time. But don't use metformin for losing weight in non-diabetic patients. Using metformin to guard against the occurrence of diabetes in patients with having glucose intolerance, this is accepted because several studies showed that acarbose as well as metformin, lifestyle modification, these are the 3 conditions which retard the occurrence of diabetes. Metformin is the best of them, not lifestyle modification. But metformin number 1, lifestyle modification number 2, and acarbose number 3.
في حد بيقول في brother and sister with complete heart block. أخت عندهم complete heart block.
أخت أوكي.
السيستر عملت CRT for dilated cardiomyopathy.
اوكي.
والبراذر حط DDD وجاله heart failure manifestation during follow up, and the echo showed hypertrophic non-obstructive cardiomyopathy with the ejection fraction of 40%.
Okay, what's the question?
غالبا عايز الopinion بتاع حضرتك، مش عارف بصراحة.
يعني this is a familiar cardiomyopathy. العيانين اللي عندهم conduction defects بنفكر في حاجات معينة زي إمرين، لامين A and C اتكلمنا عنهم المرة اللي فاتت. So this is a familiar cardiomyopathy. The same genetic abnormality can produce different phenotypes in type as well as in severity. So you can get because of beta myosin heavy chain, which is a known common form of genetic variant or genetic mutation in hypertrophic cardiomyopathy, can produce dilated cardiomyopathy, and the non-compaction, same gene abnormality, and can produce severe cardiomyopathy in certain patients of the same family, same genetic abnormality, and very mild cardiomyopathy. The genes فيها enhancers, فيها silencers, فيها modifiers, وبعدين بالإضافة إلى كده environmental interaction. So it's a complex subject, not clear at the present time. But this patient obviously should be treated. At the same time, should get the genetic counseling about their future. And if you are having a facility إنك أنت تعمل genetic study, lamin A1C is important, amyloidosis is important, emerine is important, because these are the three conditions that are associated with conduction defect, particularly lamin AC. Lamin A and C is a protein which is lining the inner.
الصوت راح يا دكتور محمد. دكتور محمد حضرتك سامعني؟
الصوت راح يا سر شوية. يبدو ان عنده مشكلة في النت دكتور محمد.
هو شكله كده طلع من على الصورة، اختفت وكل حاجة.
Let us wait a few minutes لحد ما دكتور محمد يجي تاني.
الو.
لسه ياسر ما فيش اتصال.
محمد هو بيحاول يدخل تاني.
اوكي.
ماشي. انا هحاول كده عشان دكتور محمد في صعوبة في الدخول، هحاول اشغل السبيكر، ما اعرفش حضرتك تسمعوني ولا لا. لو سامعين اوكي، لو مش سامعين قولوا لي بس. اتفضل كده يا دكتور محمد.
كده سامعني؟
سامعين كده يا دكتور محمد عبد الغني، حضرتك سامع كده؟
انا سامع. انا سامع.
اتفضل يا دكتور محمد.
اميكابتيف ميكاربيل، لو انت بصيت الريت اوف رايز اوف ليفت فنتريكولار بريشر اللي هو دي بي دي تي، دي is an index of contractility, a very reliable index of contractility. If you give الانوتروبس اللي احنا واخدين عليهم زي مثلا دوبامين، ميلارينون، نورفين، اتسترا، كل دول بيزودوا الدي بي دي تي. It turns out انك انت if you do that you increase mortality because you increase calcium load and delayed after depolarization arrhythmia. But Mecarbel, omecamtiv mecarbil, does something different. It increases the duration of systole, doesn't increase the rate of rise of ventricular pressure. So it's hopeful that if you alter the mechanism, it might increase cardiac contractility at the same time does not increase mortality. This is the point which is now being studied. Whether it's going to be true or not, we have to wait. So this is the ريسيجوات. هو الفكرة ان ريسيجوات انك انت طريقة عشان تبريزيرف نيتريك اوكسيد. So definitely there is trials with the HFrEF and the HFpEF. It might work. I don't know whether it's successful or not, but it's an idea. Remember, in the nitric oxide is one of the counterbalancing mechanisms that are protected, exactly like BNP. So if you have sympathetic stimulation, renin-angiotensin aldosterone activation. On the other hand, you have a counterbalancing beneficial hormonal changes, including nitric oxide. So if you decrease the degradation of nitric oxide by real, then this might be very helpful. So it's a promising something, but not in the guidelines, but we have to wait until we get the results of the study. So this is mecarbel, captive mecarbel, as well as reosequel.
طيب
But not sildenafil in patients with HFpEF.
تمام. هو في سؤال تاني في استعمال ال SGL2 inhibitors في ال HFrEF diabetic او not diabetic، في اي اخبار عن حاجه زي كده؟
ما احنا اتكلمنا عليها، مفيش شك ان هم they are helpful they are helpful not only because they diurese the patient. It seems in هم they antagonize the renin-angiotensin aldosterone system. So this is very well accepted in the diabetic guidelines. It's recommended in these patients. We know this is a very important group of drugs. A group of drugs if the patient is diabetic, then there is no question about that. If the patient is not diabetic, then it's an understudy. So it's not recommended at the present time to use it in non-diabetic patients for the sake of treating heart failure. But if the patient is diabetic and is having a cardiovascular problem, including heart failure, then this is one of the first-class recommendations to treat heart failure. Not only because they diurese the patient, they do, but as well they are having a cardioprotective effect through antagonizing the renin-angiotensin aldosterone system and maybe other things.
طيب هو في سؤال اخير برضك يا دكتور محمد مرتبط بالHFrEF والاكسرسايز.
HFrEF ولا HFpEF؟
لا HFrEF.
ايوه احنا عندنا المحاضره الجايه HFrEF كلها.
هو HFrEF. طيب هو ريليتد الاكسرسايز ان هو نون كومبيتيتيف فيجورس اكسرسايز زي كوره.
قول تاني يا ياسر، علي صوتك.
patient with HFrEF class 2. انا بتاع راح من عندي خالص. في حد عمل شير سكرين يا جماعه؟ طيب هو واحد HFrEF class 2 symptoms وعايز يلعب non-competitive vigorous exercise.
عاوز يلعب ايه؟
non-competitive vigorous exercise.
non-competitive vigorous exercise.
فهل يعمل supervised exercise test قبليها ولا exercise to the level that does not make him complain؟
يعني عيان عنده stage 2. خد بالك stage 2 انت بتتكلم على نيويورك هارت اسوسيشن كلاسيفيكيشن.
تمام.
وبالتالي ده هو stage C heart failure. So these patients are not advised ان هم يعملوا vigorous exercise. So testing them by the treadmill is not going to help in any way. But if the patient is in stage 2, that he is just doing his ordinary activity, that the classification لمجموعة stage C. Stage C, there is no vigorous exercise. He should be kept active, doing his daily activities, no competitive activities, no vigorous activities. That's not definitely going to improve his cardiac function ولا peripheral musculoskeletal performance. So no vigorous exercise.
تمام. خلاص شكرا يا دكتور محمد. ده كان السؤال الأخير الموجود يعني.
شكرا للجميع وميعادنا بإذن الله يوم الجمعة 7:30 هنتكلم على مانجمنت اوف هارت فيلير HFrEF.
بإذن الله في انتظار حضرتك. شكرا جزيلا.
شكرا يا دكتور محمد.
شكرا.
شكرا.